Dr. Mvere Chatora, you should be able to share your screen.
Okay, can you see my screen now?
Yes, we can see it. Let me quickly move to your introduction.
Okay.
So thank you for graciously agreeing to present earlier than your time slot. Dr. Maita Mvere Chatora is a specialist radiologist at the World Women Clinic and MIC Radiology Group. She obtained her medical degree at the University of Zimbabwe, then moved to the United Kingdom for postgraduate training. She completed a 5-year radiology training program at the Nottingham Radiology Training Scheme, becoming a fellow of the Royal College of Radiologists. Subsequently, she completed a 2-year breast imaging fellowship at the Nottingham Breast Institute. She also has a subspecialty interest in general women's imaging. Dr. Mvere Chatora will be speaking about the role of radiology in evaluation and management of endometriosis.
Right, thank you so much for the introduction, Dr. Gwanzura. I'm going to switch my camera off. My network has been acting up this morning, my Wi-Fi, but I will switch it on at the end for question time. Okay, so I'm going to be speaking on the role of radiology in evaluation and management of endometriosis. So the outline of my talk, I'm going to be going through the different endometriosis phenotypes from a radiological perspective, and I'll also briefly mention the extrapelvic endometriosis, and then I'll talk about the diagnosis and preoperative assessment of endometriosis using ultrasound and MRI imaging. So I'll spend relatively more time talking about ultrasound compared to MRI because that's the modality that's most accessible to women in our country. So as we've already heard this morning, endometriosis is a chronic, currently incurable, estrogen-dependent inflammatory disorder resulting in attachment and growth of endometrial-like tissue outside the endometrial cavity. Laparoscopy remains the reference of standard for diagnosis of endometriosis, and there's often a massive diagnostic delay. So the average time from onset of symptoms to the time that women receive the diagnosis is globally on average 7 years. So most endometriotic deposits are located in the pelvic cavity, the most common locations being the rectocervical space, the pouch of Douglas, and the rectosigmoid colon. As we've already heard, extrapelvic endometriosis is rare. So it occurs in about 8.9% of cases of endometriosis, but it can go to various locations within the body. So here are a few examples. So on the left, you can see an example of scar endometriosis. This usually occurs after surgical or gynecological procedures. In the middle, you can see an endometriotic deposit and the umbilicus, both on ultrasound on the top and on MRI at the bottom. And on the right, it can also involve the diaphragm and the pleura, leading to catamenial pneumothorax, as seen on the CT and chest X-ray. It can also involve other bowel structures like the cecum, the appendix, the small bowel, abdominal organs like the kidneys, the liver, the pancreas, and more unexpected locations as well, like the nasal mucosa, the brain, the eye. So it's important for us all to be very aware of this very unusual presentation of endometriosis in women of reproductive age. So there are three phenotypes of endometriosis. So starting off with the superficial or peritoneal endometriosis, which is found in 80% of women. So from a radiology point of view, this is often not seen on MRI or ultrasound. But what is easily seen is the ovarian endometrioma. So these are the endometriotic cysts, also known as chocolate cysts. And the top image shows the classic appearance, the classic ground glass contents of the endometrioma. And you can also see the bottom one, what an endometrioma looks like on MRI. So it can also manifest as deep endometriosis, so deep lesions that infiltrate the peritoneal surface more than 5 millimeters, a condition known as deeply infiltrating endometriosis. So on the top image, you can see a deep endometriotic nodule in the rectosigmoid colon, and you can also see a lesion on the bottom MRI image as well. Some authors now include a fourth group, which is the pouch of Douglas endometriosis, pouch of Douglas obliteration group. This is the worst case scenario. This is also called the stage 4. And this is when fibrosis and adhesions lead to obliteration of the pouch of Douglas and distortion of normal anatomy. So the first line imaging modality when a patient is suspected to have endometriosis is the basic transvaginal ultrasound scan. And this consists of evaluation of the uterus and the ovaries, as well as the pouch of Douglas for the presence of fluid or mass. The advantages of ultrasound over MRI is that it is more accessible, it is cheaper, it is quicker. And the detection of endometriosis is based on the presence or absence of hard markers. The hard markers. Hello? Hello, so I think someone's mic is on. So hard markers are objective findings of endometriosis seen on ultrasound scan. So this is commonly endometriomas, but can also be hydrosalpinx. And it was generally believed that it wasn't possible to visualize the other phenotypes of endometriosis on ultrasound. But the absence of a hard marker alone cannot rule out overall endometriosis. And so oftentimes women are taken to theatre following this basic pelvic ultrasound scan, who are often found to have extensive disease at laparoscopy. And this has several disadvantages. There is no detailed surgical planning. If a woman did have significant bowel endometriosis, this would mean an unplanned intraoperative colorectal consultation or need to come back for a second operation. The patient would not be properly consented, so it would be very non-specific or broad consent. Oftentimes there would be suboptimal cytoreduction of endometriotic disease at first surgery, resulting in a potentially higher complication rate, and the patient would be subject to two-step laparoscopy for high-stage disease. So in an attempt to improve the preoperative diagnosis or detection of endometriosis, Okara et al. In 2006 first introduced the concept of soft markers. So soft markers are subtle subjective sonographic findings that increase the likelihood of there being a diagnosis of endometriosis. So these are ovarian immobility and site-specific tenderness. And so Okara found that 53% of women who had a normal ultrasound scan based on the presence or absence of hard markers had soft markers. And of these, 73% had endometriosis on laparoscopy. A few years later, in 2009, a method to diagnose deeply infiltrating endometriosis using transvaginal ultrasound scan was described. And since then, its accuracy for the diagnosis of endometriosis, of deep endometriosis, has been well established in the literature, with a sensitivity of 91% and specificity of 97%. So fast forward to 2016, a consensus opinion was published by the International Deep Endometriosis Analysis Group. So this was a group of 29 authors, including gynecologists, radiologists, and laparoscopic surgeons from 13 countries. And they got together and they came up with a 4-step systematic approach to the sonographic evaluation of the pelvis. And they call this the deep endometriosis ultrasound. So this not only looks at the ovaries and the uterus, but it also incorporates the soft marker evaluation, so ovarian mobility. It also looks at the bowel, the uterosacral ligaments, the bladder ureters, the vagina, rectovaginal septum, and the pouch of Douglas for obliteration and nodules. So what does this deep endometriosis ultrasound mean for the patient? It means that detailed surgical planning can now take place involving a multidisciplinary team Colorectal consultation can now take place preoperatively if the patient is found on the deep endometriosis ultrasound to have bowel endometriosis. Consent can be more specific. There's a higher chance of achieving optimal cytoreduction of endometriotic disease at the first surgery, resulting in a lower complication rate. And there's a higher chance of just needing one-step laparoscopy for higher stage disease. So going to the 4 steps of this deep endometriosis ultrasound protocol. So the first step is the routine evaluation of the uterus and adnexa for sonographic signs of adenomyosis or the presence or absence of an endometrioma. So this is basically the basic pelvic ultrasound scan that we're all used to. So this is the classic appearance of an endometrioma, and it should be, the sonographic characteristics should be described using simple descriptors from the IOTA classification system, which for a typical endometrioma is a unilocular tumor with ground glass echogenicity. So the ectopic glands of adenomyosis manifest on ultrasound as subendometrial echogenic linear striations or nodules, an irregular endometrial myometrial junction, and the presence of myometrial and subendometrial cysts. And so you also get muscular hyperplasia, which manifests on ultrasound as focal or diffuse myometrial bulkiness. So on the image on the left, the top image, you can see asymmetrical thickening of the anterior myometrium relative to the posterior myometrium. And the bottom image just demonstrates the heterogeneous internal echotexture with the typical Venetian blight shadowing and increased vascularity. So the next 2 steps of the protocol are the dynamic portion of the examination. So firstly, the evaluation of transvaginal sonographic soft markers. So looking for site-specific tenderness and ovarian mobility. So pressure is applied to the abdomen while pushing with the transducer to check for any sites of tenderness and also to assess for ovarian mobility. So in this clip, you can see normal ovarian mobility. You can see the ovary sliding freely against the surrounding structures. Whereas in this clip, it shows ovarian immobility. So here you can see that the posterior border of the right and left ovaries are moving with the surrounding fat and not sliding freely against it, indicative of adhesions. Also, the probe is in the midline, applying pressure, but the ovaries are not moving apart. This is known as the kissing ovary sign, which refers to the appearance seen when both ovaries are touching each other in the midline and the pouch of Douglas, usually due to pelvic adhesions. So the next step is to check for the pouch of Douglas obliteration using real-time ultrasound-based sliding sign. So as an assessment of the ovarian mobility, pressure is applied to the abdomen. And here you can see the smooth sliding of the posterior uterine fossa, serosa, over the bowel at the fundus. But more importantly, you can see sliding behind the cervix. And this is where pouch of Douglas obliteration mainly occurs. You can also see some fluid in the pouch of Douglas, which suggests a non-obliterated pouch. So a positive sliding sign reflects a non-obliterated pouch of Douglas with high confidence, with the positive sliding sign having a high 93% negative predictive value. So in this clip of a negative sliding sign, pressure is being applied to the uterus, but the structures posterior to the uterus are not sliding smoothly against the posterior uterine serosa. There is also a fixed ovary posterior to the uterus and a subtle hypoechoic nodule posterior to the uterus at the level of the internal cervical os, suggestive of deep endometriosis. When the uterus is retroverted, in addition to sliding of the uterus, again, the presence of fluid behind the cervix makes it easier to conclude that there are no adhesions. So on this clip, there is no sliding of the uterus. So this is a negative sliding sign. And you can also see a large hypoechoic nodule posterior to the cervix, suggestive of a deep infiltrating endometriotic nodule. So the last step is to assess for, excuse me, deep infiltrating nodules in the anterior and posterior compartments. So the anterior compartment, this involves evaluation of the walls of the urinary bladder. So the trigone, the vesical dome, but also assessment of the ureter and assessing for uterovesical obliteration. So on this image on the left, you can see that the transducer is placed into the anterior vaginal fornix, and also the patient should be told not to completely empty their bladder so that there's a little bit of urine in the bladder, which facilitates evaluation of the walls of the bladder. So on the left, this is the normal appearance. You can see the trigone in yellow, the bladder base is the pink line, and the bladder dome is the right line. But on the right, you can see highlighted by the asterisk, an endometriotic nodule, which involves the dome of the bladder wall projecting into the lumen. So finally, the transducer is placed into the posterior fornix of the vagina and slowly withdrawn through the vagina to allow visualization of the posterior compartment. So this includes the rectovaginal septum on the left, then the uterosacral ligament, and assessment of the rectum and rectosigmoid colon. So on the left, you can see the probe in the posterior vagina, and you can see a length of normal rectum, demonstrating normal thickness and echogenicity of the walls of the rectum. But on the right, you can see the presence of a deep infiltrating endometriotic nodule. So sometimes the nodule is associated with retraction and fibrosis, resulting in the so-called Indian headdress or moose antler sign. Okay, so now that we've finished the deep endometriosis ultrasound, I've already stated that we cannot generally see superficial endometriosis on ultrasound. So there is a new technique that has been developed called saline infusion sonopodography. And this is a similar technique to sonohysterography, in that normal saline is introduced into the pouch of Douglas through the uterus and fallopian tubes via intrauterine catheter. And then you're able to assess the contours and walls of the peritoneal surfaces. So this slide just shows some features of superficial endometriosis using this technique. So you can see small hyperechoic nodules, filmy adhesions, and peritoneal pockets with incomplete septations. Right, so we'll now move on to MRI. So most professional organizations, including the European Society of Urogenital Radiology guidelines, recommend MRI as a second-line technique examination after ultrasound scan in the evaluation of pelvic endometriosis. It is also usually performed before surgery for optimal pre-op staging, but there are some requirements that need to be observed to provide optimal imaging. So namely administration of bowel prep and an antiperistaltic agent. So as on ultrasound scan, we can see features of deep endometriosis on MRI. So this is the typical classical appearance of an endometrioma on MRI. So on the left, you can see a low, high T1 signal intensity on the left, and you can see low T2 signal intensity on the right. This is known as the shading sign, and it's a result of high protein and blood products and iron from recurrent hemorrhage. Another important sign is called the T2 dark spot sign. And you can see just that dark spot on the T1 and T2 weighted imaging. And this is useful. It's a sign of chronic hemorrhage, useful to differentiate between an endometrioma and a functional hemorrhagic ovarian cyst, because sometimes hemorrhagic cysts can demonstrate similar appearance to endometrioma on MRI. So we can also see features of bowel endometriosis on MRI. So these images just demonstrate a lesion at the rectosigmoid junction, demonstrating the mushroom cap sign. So this is where the low intensity of the mushroom base is due to hypertrophy and fibrosis, of the muscularis propria, and then the intact submucosa and mucosa of the wall of the rectum is projected into the bowel lumen, given that mushroom cap appearance. So MRI has a larger field of view compared to ultrasound, and we can also detect extrapelvic endometriosis. So here you can see a heterogeneous lesion in the right rectus abdominis muscle. So which is more accurate for detecting deep infiltrating endometriosis, transvaginal ultrasound scan versus MRI? So in this systematic review and meta-analysis done in 2018, it was found that the diagnostic performance of transvaginal ultrasound scan using a protocol, for example, the IDEA protocol that I described earlier, versus MRI was similar, with a sensitivity of 85% for both of them, and specificity of 96% and 95% for MRI and transvaginal ultrasound scan, respectively. So this confirms the role of transvaginal ultrasound scan as a cost-effective first-line technique. MRI, however, has an advantage when it comes to assessing for post-op recurrence. So the 5-year disease recurrence rate of endometriosis after surgery ranges between 30 to 50%, and repeat surgery rate reaches 51% for 10 years. So MRI is quite good at distinguishing between recurrence versus post-op fibrosis or adhesions. So fibrosis on MRI has very low signal intensity on T1 and T2 weighted imaging, whereas recurrence has bright spots on T1 fat-sat imaging, which are areas of hemorrhage within and areas of inflammatory change, basically. So this is just an example to show you. So on the left side, you can see the low signal intensity in this patient who's had a hysterectomy. You can see what looks like a possible fibrosis at the vaginal vault. But on the fat-sat image, you can see those foci of high signal intensity, indicating that this is actually active disease and therefore recurrence. So to summarize, laparoscopy remains the standard of reference for endometriosis. The statement is supported by the low accuracy of imaging techniques to detect superficial endometriosis. However, the transvaginal ultrasound scan using a standardized protocol, like the IDEA protocol I described, and MRI have very similar high diagnostic performance for diagnosis of deep endometriosis. So transvaginal ultrasound scan is therefore a very cost-effective first-line imaging technique, important in a country like ours with relatively limited resources. But MRI has an important role as a second-line imaging modality, useful for pre-op surgical planning, problem-solving in complex cases, and for assessment of post-op disease recurrence. Thank you very much for listening. This is the end of my presentation.
Thank you for the really interesting presentation, Dr. Mvere Chatora. I'll now open the floor for questions. At the moment, I don't see any questions within the chat. Okay, yes, I see a raised hand. Dr. Buma, you can go ahead.
Hello, hello, Dr. Chatora.
Hi,
hello.
Dr. Buma. Hello, Doc. How are you?
Thank you very much for such a detailed presentation. Just wanted to find out, do you have any dedicated people, or does anyone do the assessment, vaginal assessment for endometriosis?
You mean dedicated people in terms of?
So I mean, like, because one of the things in terms of outcome, it's not that everyone else can do it, because you just need someone who obviously has got the insight to see what they're seeing. Because we also have the similar problem of always incomplete thing, and then units usually have dedicated people who specifically deal, like for example, if you suspect endometriosis, then you send to a certain person in the department.
Yes, exactly. Well, certainly yes, and that's one of the disadvantages of ultrasound, is that it is operator dependent.
Yes.
And yes, that's a very big problem. But if you're asking specifically where I practice, yes, certainly I am usually the person requested to do those sort of ultrasound scans. But we are in the process of training our sonographers to be able to do this technique as well, because it's important to educate, to train, and that's why the CMEs are so important, so that we increase awareness, we increase the training, etc. But you're right, it's important to refer to someone who actually knows how to do the protocol.
Thank you, sir.
Hi,
So
Dr.
there's a
Gusha.
question. Okay.
Thanks, Maita, for such a wonderful presentation. I think mine is just a comment. I think we are also seeing the same thing, in oncology, where a lot of studies, especially in endometrial and cervical cancer, are showing that an expert ultrasound scan is as good as an MRI in preoperative staging of these patients. And I think, like what Eton has said, I think the issue is we just need more and more dedicated people whom we know we can refer for these expert ultrasounds. Thank you very much for such a wonderful talk.
You're welcome.
So there's a question in the chat box from Dr. Virenga. He's thanking you for your presentation and asks, what is your experience in diagnosing the various manifestations of endometriosis? And he has followed up with a second question: what level of assessment is available to the women of Zimbabwe?
Okay, so to answer the first question, in terms of my experience of the features, the phenotypes that we see, as I mentioned in the presentation, endometriomas are very easy to see. So I would say in women who are referred for suspected endometriosis, you see endometriomas, I would say in about 10 to 15% of those patients. In another subset of patients, I would say another 10%, then you see the soft markers. So kissing ovary sign is a sign that I see quite a lot. You also see hemorrhagic. Sometimes you're lucky, and I think you can see superficial endometriosis on ultrasound. So sometimes you see hemorrhagic fluid and you see little nodules along the peritoneal lining. But apart from that, those are the major signs that I would say that I see. In terms of what's available to women in Zimbabwe, as going back to Dr. Vuma's question, yeah, the basic pelvic ultrasound scan is what's available. So unless if that sonographer or radiologist or gynecologist sees an endometrioma, I think that's basically where we are at the moment, the basic transvaginal ultrasound scan. I don't know if that answers your question.
Thank you, Dr. Director. I think Dr. Virenga hasn't come back with a further question. I see a hand raised by Dr. or by Tavaziwa Mzamiri. May you unmute yourself and go ahead?
Thank you very much. Just a question. What's your position on point of care ultrasound scan in terms of being a clinician-directed imaging? So just to qualify, in my practice, I do my own scanning, pretty much following the protocol that you've described. And that tends to help when it comes to surgery. But what are your thoughts about that? Yeah,
no, I think it's good. I think it's as much as possible, and that's something that we're trying to do is at the Well Women Clinic in particular, is to offer one-stop visit for patients. So I think the greater the number of people who are able to do these scans, the more we're able to offer an efficient service towards patients, I think that's excellent. And especially if it's the person who's going to be doing the laparoscopic surgery, to be able to visualize on ultrasound as well, I think that's a great move, definitely.
All right, thank you.
Thank you, Dr. Mvere Chatora. And I would like to take this opportunity to thank all the speakers in this first session on the basic science of endometriosis, Dr. Ziki, Dr. Guja, Dr. Mvere Chatora, and we'll have the recording from Prof. Kakstein uploaded on the YouTube link. Just a reminder that you can register using the details posted just now within the chat. It's time for our tea break, but it's going to be a working tea break. We are really grateful to our sponsors, Pulse Pharmaceuticals, and they have a short presentation for us on microphones muted. If you're using mobile devices, make sure you're not playing around on the screen as it actually draws on our screen. And if you're failing to access the registration link, you can send your email or upload your details on the chat in order to register for the day.
Okay, can everyone see my slides?
Yes, Dr. Guja, we can see them perfectly. Let me move to your intro. So Dr. Boswell Guja is qualified as an obstetrician gynecologist in 2011 and is a member of the RCOG and FCOG. After that, he acquired a diploma in minimal access surgery and has extensive experience in endometriosis surgery. He's board certified gynecological oncologist and holds an MPhil from the University of Cape Town. In his current capacity, he is one of the 2 lead gynecological oncology surgeons at Parengatwa Group of Hospitals. He's involved in the running of the gynae oncology services, including cervical cancer screening services, and also chairs the gynae oncology tumor board. His main areas of clinical interest are gynecological cancer screening and minimal access surgery. Endometriosis, risk factor for ovarian malignancy, is the question that Dr. Guja's talk is focusing on this morning. You may take the virtual podium, Dr. Guja.
Okay, thanks, Dr. Gwanzura, for the kind introduction. I think I've done a lot of endometriosis surgery and I've done a lot of oncology surgery. But I think I would be honest to say that endometriosis surgery is way more challenging than gynecology surgery. So I'm here going to try and attempt to answer this question whether endometriosis is a risk factor for ovarian cancer. I have no conflict of interest, and this is going to be the outline of my presentation. I'm going to kind of like define, I think Dr. Ziki has done that very well. I'm going to kind of like go through a couple of epidemiological studies. I'm going to compare endometriosis-associated ovarian cancer versus pure ovarian cancer, if I may put it that way. One slide on management, and then communication of risk to the patients, and the take back to the clinic message. So I think Dr. Ziki has done this already. Endometriosis is the presence of endometrial glands and stroma outside the uterine cavity. It's a common condition with an incidence of 10%, depending on how you define it, and the code characteristics. The pathological diagnosis is benign, but however, I think all of us on this platform know that this disease often recurs. And what is of interest is that this disease can really metastasize. What I also find very interesting is that it might be a delay in making a diagnosis of even up to 8 years, which has been noted in some studies, especially in our setting where women complaining to chronic pelvic pain, they're labeled chronic PID and giving multiple courses of antibiotics without pausing to think, about endometriosis. So Samson in 1925 first described the association between endometriosis and ovarian cancer. This has been known for a very, very long time. And then Scott in 1953 kind of like came up with a criteria that must be met to say ovarian cancer is arising from endometriosis. This has somewhat been modified over the years, but basically what Scott said was there should be coexistence of benign and malignant tissue in the same ovary. So if you've got cancer in one ovary and endometriosis in the ovary, it doesn't quite meet the criteria. The cancer must be identified to arise from the tissue and not to be invading from another source. And the finding of tissue resembling endometrial stroma surrounding characteristic endometrial glands, and the finding of old and not fresh hemorrhage. Fresh hemorrhage might just be trauma from the surgery. So the finding of old blood quite supports the diagnosis. There should also be a microscopic section showing benign endometriosis contiguous with malignant epithelium. So this is what Scott described as the characteristics that we met, what pathologists must look at to say that endometriosis, ovarian cancer is arising from endometriosis. There's this study that was done looking at the association between endometriosis and ovarian cancer. It was done in Taiwan, National Health Insurance research database and the Registry for Catastrophic Illness Patients. It was a retrospective cohort study of 14,000 patients, carried over a period of 14 years. They looked at 240,000 women aged between the age of 20 and 51. So they included cases in which there was no histological confirmation, which were labeled recalled endometriosis. So the patient recalled, or there was some documentation in the notes of endometriosis, but no histology. And they also looked at women with tissue-proven ovarian endometriosis. So the incidence rates for epithelial ovarian cancer ranged from 1.90 in women with recalled endometriosis, but it was as high as 18.7 in women with tissue-proven ovarian endometriomas. So after adjustment for PID, infertility, Charlson comorbidity index, and age, the hazard ratios ranged from 1.90 to 18.6. So there was a strong association between the diagnosis of endometriosis and ovarian cancer, more so in patients with tissue-proven endometriosis. Then Koch et al. In 2015 tried to answer the question whether endometriosis was associated with just ovarian cancer or other cancers like endometrial cancer, breast cancer, colorectal cancer, or any other cancers. So they looked at women that were older than 20 years between 2003 to 2005, and they randomly sampled them again from the National Health Insurance Research Database in Taiwan. So the cohort included 2,300 women with endometriosis, including about 760 with poor adenomyosis. They compared them to a cohort of about 9,064 women without any diagnosis of endometriosis or adenomyosis. These women were followed up until incident cancer dropout, and that was up to 31 December 2008. So what they found was very interesting, that ovarian endometriosis group was associated with an increased risk of subsequent ovarian cancer with a hazard ratio of 4.37. What I also found interesting was that the adenomyosis group was strongly associated with both ovarian cancer with a hazard ratio of 5.50 and endometrial cancer with a hazard ratio of 5.13. They also noted an increased risk of colorectal cancer in women with adenomyosis with coexistent endometriosis at other sites, with quite a very high hazard ratio of 13.04. However, there was no statistically significant increased risk of breast or other cancers that was observed. So they noted that there was actually a very strong association between endometriosis and ovarian cancer, and adenomyosis and ovarian cancer and endometrial cancer. So what are the histological subtypes of ovarian cancer? So malignant epithelial tumors are the commonest types of ovarian cancer, making up 90% of all the cases of ovarian cancer. It's not, what we now know is that ovarian cancer is not a homogeneous disease. It's a group of diseases with different morphology and biological behavior. And 5 main types have been basically identified. But I think 2 of them, the endometrioid carcinomas, which make up 10% of endometrial cancers, and the clear cell carcinomas that make up another 10% of endometrial cancers, have been shown to be associated with endometriosis. So in this study that was done by Kuma et al., they compared endometriosis-associated ovarian cancer versus women with ovarian cancer without endometriosis. It was a retrospective study comparing 42 cases of ovarian cancer in women with endometriosis versus 184 cases of ovarian cancer without endometriosis. So the typical patient who comes with endometriosis-associated ovarian cancer is younger. They're usually in their early 50s, compared to women with ovarian cancer who normally present in their early 60s. Most women with endometriosis and ovarian cancer present with low-grade disease, 21% versus 8%. So these patients come with early-stage tumors, usually stage 1 and stage 2. I've already alluded to the fact that clear cell and endometrioid are the common histological subtypes associated with endometriosis-associated ovarian cancer, whereas mucinous tumors were more prevalent in ovarian cancer. What I found very interesting was that there was quite a huge difference in the median survival, 199 versus compared to 62 months, and also in the 5-year survival, 62% versus 51%. So it seemed that women with ovarian cancer from endometriosis fared better. After controlling for age, stage, grade, and treatment, association with endometriosis was not an independent predictor of better survival, though, in patients with ovarian cancer. I think Ziki kind of like asked me to talk to kind of like zoom a bit more into this, but unfortunately the data is not still very clear, the pathogenesis of ovarian cancer in endometriosis. So the exact mechanism of malignant transformation is still unknown, but what is known is that atypical endometriosis shares the same genetic alteration with clear cell carcinoma, and it could represent a precursor of a clear cell carcinoma. So there was this study done by Xiao in 2012, where they looked at the molecular alterations on benign ovarian endometriosis, atypical endometriosis, and clear cell carcinomas. They looked at these at BAF250A, which is a protein encoded by the ARID1A gene, which is a major tumor suppressor gene in ovarian clear cell carcinoma. They also looked at the hepatocyte nuclear factor 1B, estrogen receptor, progesterone receptors, and P53. What they found was that clear cell carcinomas, but not pure serous carcinomas, had loss of BAF250A expression, HNF upregulation, and the loss of expression of ER and PR. They also noted that atypical endometriosis and with adjacent, where there was atypical endometriosis adjacent to a clear cell carcinomas, there was loss of the BAF250A expression, 38% versus 57.7%. So this loss of expression was higher in women with clear cell compared to those with just atypical endometriosis. The same thing with HNF upregulation, 53 versus 92%, more common in clear cell carcinomas. Same as loss of ER and PR expression. What I found very interesting was that even 20% of benign ovarian endometriosis also had similar characteristics. That loss of the BAF250A expression, 33% had upregulation of the NHF1B, and 23% had loss of ER and 50% had loss of PR expression. But however, I think the overall message was that the concurrent loss rate of loss of BAF250 overexpression, HNF1B upregulation, and loss of ER expression was not observed in any benign endometriosis. So the combination of those three at the same time was not common in women with benign endometriosis. But however, this was increased to about 23.1% in atypical endometriosis and further increased to 42.3% in women with clear cell carcinomas. So what was the take-home message from this paper that was published in 2012? So actually, molecular alterations accumulate in a stepwise manner along the transformation process from benign endometriosis through atypical endometriosis to clear cell carcinoma. So this data suggests that a portion of benign ovarian endometriosis has already undergone genetic alterations that lead to aberrant protein expression, possibly conferring a high risk for malignant transformation. But I think the bottom line is what causes these genetic alterations that will then lead to ovarian cancer. I think the answer is unknown. There are a lot of theories that I will not go into, but one of the theories is that the iron that is produced in the fluid of the endometriotic cyst promotes oxidative stress, which may then cause these genetic alterations. So endometriosis is relatively common. So when should we then suspect that we are now dealing with endometriosis-associated ovarian cancer, not just endometriosis? Unfortunately, it's not an easy question to answer. Lim et al. Published two papers, one in 2010 and one in 2009, where they showed that endometriosis-associated epithelial ovarian cancer shares the same symptoms with endometriosis, including dysmenorrhea, dyspareunia, and infertility. They also showed that symptoms in endometriosis-related ovarian cancer were similar to those in endometriosis, dysmenorrhea, 31.3%, dyspareunia, and infertility. So the symptomatology is almost exactly the same. But however, the limitation is that this was a retrospective study and kind of like studies and they prevent a clear delineation of when symptoms began. So in a nutshell, what is the message that you should take to the clinic? If you've got a perimenopausal woman with a diagnosis of endometriosis, if you start getting acute or subacute exacerbation of their symptoms, this might suggest endometriosis-related ovarian cancer. But this should be considered in conjunction with imaging and measuring some of those tumor markers like CA125 and HE form. What is the management of women with endometriosis-associated ovarian cancer? I've already alluded to the fact that the diagnosis is difficult to make, and at times diagnosis is only made after surgery for endometriosis. And I want to highlight that biopsy might be helpful in cases where there's suspicion prior to surgery. But however, once confirmed that a woman is endometrioid or a clear cell carcinoma arising from endometriosis, I think the standard treatment for ovarian cancer should be applied. So what is the prognosis for these women when they're diagnosed with cancer? I kind of like bring you back to the paper published by Kuma et al. In 2011. The median survival was better, 5-year survival was better, but after controlling for age, stage, grade, and treatment, association with endometriosis was not an independent predictor of better survival in ovarian cancer. So I think this is the most important slides of my presentation. So how do you communicate this risk to the patient? There was a paper that was published in 2018, which was a cohort study of 280,000 women with nearly 5 million person years of follow-up from 1981 to 2020. They compared 17,000 women with a diagnosis of endometriosis versus 80,000 women with no evidence of endometriosis at laparoscopy, compared to 160,000 women with laparoscopic sterilization and another 17,000 age-matched women from the general population. I think the take of what this paper found was that women with endometriosis get an increased risk of ovarian cancer when compared to the general population. But if you look at the hazard ratio there, it's 1.77. when they compared to women who just had laparoscopic sterilization, but no diagnosis of endometriosis, there was a similar hazard ratio of 1.75. So when you are faced with a patient in front of you in the clinic, it's very important to communicate risk, because a patient is going to read an article that the risk of endometrial cancer, ovarian cancer, when you've got endometriosis, is 70% higher. And they're going to come into the office panicking that, oh, should I have my ovaries taken out? So the conclusion from this paper was that women with endometriosis have a higher chance of developing ovarian cancer in comparison with the general population in women with laparoscopic sterilization. Hazard ratio was 1.77. So we know that the background risk of developing ovarian cancer is about 1.4%. So in women then with endometriosis, the absolute risk is very low. It's less than 3%, it's about 2.4%. So I think this is the message that should be given to women when they come for consultation, that the risk of ovarian cancer is higher, but the absolute risk is not very high. So what message should we take to the clinic on Monday? I think from endometriosis is a common condition. It is associated with ovarian, endometrioid, and clear cell carcinomas. And in association, the mechanism is not very clear. There are a lot of theories, but at this moment, there is no clear mechanism that is absolutely certain. Diagnosis may be difficult to make, and acute exacerbation of symptoms in a perimenopausal woman must prompt more investigations to exclude endometriosis-associated ovarian cancer. But I think the take-home message is that the overall risk is low. I think the prognosis for these women is actually good. I think that is my last slide. Thank you very much for taking your time to listen to my presentation.
Thank you very much, Dr. Guja, for that enlightening presentation. So there's a typical endometriosis that can potentially increase your risk of getting not only ovarian cancer, but endometrial cancer and colorectal cancer. So slightly increasing the risk for the woman with endometriosis. I'm going to open the floor for questions. Okay, so I have a hand raised by Dr. Buma. Dr. Buma, may you please go ahead? Dr. Buma, may you unmute yourself and go ahead?
Hello?
Yes, we can hear you now. Please go ahead.
Thank you. Thanks a lot, Dr. Guja, for the wonderful presentation. Just wanted to find out from that paper, how did they define atypical endometriosis? And also the other thing is that obviously if you do a sterilization, how do you then diagnose deep endometriosis? Because obviously it's only look at the superficial structures. Thank you.
Okay, I think thanks a lot, Dr. I think what was mean it's about that some women laparoscopic sterile but deep endometriosis, but basically they will take a history, and these are women that's coming for routine sterilization, and then take a history of any symptoms suspicious of endometriosis. And if they had they'll probably then would be investigated and then determine whether they depend on endometriosis or not. If not, then when it's laparoscopy, then they would look and see if there were any lesions that were suspicious of laparoscopy. And if they were there, then they'll be biopsy. If not, then they'll just pick sterilization. So to answer the question, it's possible that possibly a few women might have had endometriosis missed, but a lot of them had, there was a questionnaire which was symptoms of endometriosis, and there was visualization of the pelvis, and there were no ovarian endometriosis seen prior to the laparoscopic sterilization. And then coming to your question about atypical endometriosis, I think it's a kind of like histopathological diagnosis, which is usually made after excision of endometriosis, where the pathologists see some atypical or atypical cells within the endometriotic cells, and then they'll highlight it that this endometriosis doesn't look like the typical endometriosis because of the atypia. So usually get that after surgery from the pathologist.
Dr. Buma, you answered.
Thank you. Sorry. Thank you.
So we have 5 more minutes to take questions. We are currently downloading the presentation from our next speaker. So if we have more questions or comments from the floor, we'll gladly take them. So
can I try and play it
Guza,
from my side?
Sure. If you're ready to play it, you could try that.
Yeah. Okay. Let me try and play it. I've got it downloaded already.